and 1 minute past the time. So let's welcome everyone. Good morning and possible good afternoon or good very early morning. I saw a couple of colleagues from San Antonio. Welcome to this year's, this month's actually NCI Liver Cancer Program Seminar Series. It is absolutely an honor for me to introduce today's speaker, Dr. Irene OL Ng. Irene is currently the Law Q Professor in Pathology and the Chair and the Professor of the Department of Pathology in the University of Hong Kong. She is also a Director of the State Key Laboratory of Liver Research and Honorary Consultant in Pathology at Hong Kong Queen's Mary Hospital. Her research aims to define molecular and cellular mechanism and their translational application in liver cancer. And she has an active program in both basic and translation research of liver cancer using a state-of-the-art molecular approach such as omics-based analysis to capture cancer heterogeneity and to identify novel subclone and to determine signaling pathway. Now, Irene has published over 440 peer-reviewed papers, very substantial amount of publication. She was awarded an Academy of Science Prize in Medical Science in 2014 and ranked number 8 in Best Female Scientist in China in 2022, and then in 2023 and ranked 23rd, the best scientist in the field of medicine in China. Very, very high achievement. Thank you so much, Irene, for being able to accept our nomination as the speaker of this month's seminars, and especially the very late hours of yours, and I really appreciate it. So let's welcome Irene for today's talk. Irene?
Yeah, thank you, Shane. Thank you, Shane and Tim, and Anu for inviting me to join this, I think, very prestigious format or seminar. And it's my great pleasure to share what my recent work is on liver cancer. I'd like to thank you, Shane, for the very kind introduction. And let me share my screen. So my topic for today is stratification of HCC towards precision medicine. And I highlighted towards because it's really very difficult. It's not exactly precision medicine that is achieved nowadays. It's just towards, just a small step and towards this direction. So we know that liver cancer is prevalent globally. I don't need to talk much to this group because we're mostly working on liver cancer. It's very prevalent globally, and the causes, the risk factor for the liver cancer is also very well known. And we know that there is a high heterogeneity in HCC, both between patients, of course, and also when the patient has multiple tumors in the same liver, there is also heterogeneity. Not only that, there is also intratumoral heterogeneity, which means that there is heterogeneity within the same tumor. And this heterogeneity, whether it's intra-patient or intratumoral heterogeneity, would make a patient's stratification very complicated and also limit the treatment efficacy towards a particular targeted therapy or even immunotherapy. I just like to show you the most recent edition of WHO classification of HCC, and there are heterogeneous subtype. Apart from the conventional HCC, there are these subtypes like the steatohepatitic subtype, clear cell subtype. I'm not here to talk about these histology or pathology, but these subtypes will have this clinical or clinical association, very different features, and they have also different prognostic. Some are worse, some have worse prognosis. And importantly, that some of these subtypes are associated with different genetic alteration. For example, such as the steatohepatic subtype, there is this association with IL-6 activation, etc. And nowadays, we know very well that there is this cancer cell and the tumor microenvironment. And there is this dynamic interaction between the cancer cells, the cancer cells, and also the tumor microenvironment, namely the immune cells, macrophages, the vessels, etc. And this tumor microenvironment has given a lot of importance to both the stratification as well as the treatment for HCC. Let's look at an example about the immune cell heterogeneity in HCC, and there is prognostic implication. And this is a review paper, highlighting several papers in these studies. The immune high or immunocompetent HCC from patients would have a better prognosis, than those immune low or immune suppression subtype. So these are, in fact, these are useful to define or categorize HCC patients with the distinct tumor immune characteristics and prognostic implications. To this end, very recently, we also look into the immune microenvironment, particularly the immune suppression environment of human HCC. What we did is that we examined patients' HCC samples, dissociated them, and then performed single-cell RNA sequencing to analyze particularly their immune checkpoint axis. And upon the analysis, we found that this TIGIT Nectin-2 or PVRL2 Nectin-2 axis is highly expressed in HCC. And this is particularly, for example, the interaction between the T cells, Treg cells with the tumor cells. And in fact, for example, this cluster belongs to the T cells, and they have high expression of TIGIT, whereas these clusters belong to the Nectin-2 cells, and they are the TIGIT expressing cells are mainly in the T cells, whereas the Nectin-2 expressing cells are mainly in the Nectin-2 expressing cells. And furthermore, we validated this finding in both cell line as well as in animal model. And in the cell lines, we use two methods to block Nectin-2 using anti-TIGIT, using a Nectin-2 antibody and also knocking out of Nectin-2. In the cell lines, we found that both knocking out of the Nectin-2 and also using anti-Nectin-2 antibody could restore the CD4 and also CD8 T cells. And furthermore, we use the animal model, use a hydrodynamic tail vein injection model, and we found that knocking out Nectin-2 by this hydrodynamic tail vein injection model could diminish the tumor size and also restore the T effector cells, both by immunohistochemistry and also by flow cytometry. So to conclude here, in this study, we found that the anti-Nectin-2 antibody and also knocking out of Nectin-2 could restore both CD4 and CD8 T cell proliferation. And this suggests that Nectin-2 could suppress T cell proliferation at HCC progression. And this has important implication in that the Nectin-2 and the TIGIT axis, if we block them, either using anti-TIGIT antibody or a Nectin-2 antibody, could be used as a novel and promising therapeutic target for treating HCC. Furthermore, in the same study, we found that the TAM, tumor-associated macrophages, had enriched expression for multiple immunosuppressive markers. Now, this is the LAIR1, TIM3, and also another one, and another two. So this is the macrophages. We found that this tumor-associated macrophages can have increased expression of these immunosuppressive marker. In addition, when we do the correlation with these TAM, which express the cancer-promoting T2 macrophage marker, that is CD163, they had concurrent enrichment for the LAIR1 expression here using multiplex immunohistochemistry. Also, the expression of CD163, which is an M2 marker, and LAIR1 was significantly correlated both in our in-house HCC RNA sequencing cohort as well as the TCGA cohort. And high expression of LAIR1 and TIM3 is significantly associated with poorer disease-free survival, overall survival, and disease survival for LAIR1 and also TIM3. And so the single-cell RNA sequencing can help to identify novel immunosuppressive marker for HCC. Furthermore, in another study published a few years back by one of my very talented previous PhD student, Dr. Carmen Wong, I also was one of the co-author in this paper, and they found that the blockage of TIGIT or genetic ablation of Nectin-1 could sensitize the HCC cells to anti-PD-1 treatment. And we found that TIGIT Nectin-1 is important immune checkpoint pair in HCC, and additionally, Nectin-1 is upregulated in HCC. And blockade of the TIGIT or genetic ablation of Nectin-2 could sensitize HCC cells to anti-PD-1 treatment in mouse model. And therefore, the inhibitors of the TIGIT or Nectin-1 plus anti-PD-1 or immunotherapy are potentially new HCC treatment. And in fact, and the blocking of TIGIT and Nectin-2 or Nectin axis in HCC has been identified to be positive results from the phase 1B and phase 2 trial, which was reported in the ASCO meeting this year by Dr. Richard Phim and group. So TIGIT and PVR gene has a very strong immunosuppressive effect, and also a very strong co-inhibitory checkpoint here. And blocking with anti-TIGIT antibody could then suppress this immune checkpoint. And in fact, in this ASCO meeting, our paper was quoted that preclinical study demonstrated that blockade of TIGIT and genetic alteration or ablation of Nectin-1 could sensitize HCC cells to anti-PD-1 and anti-VEGF therapies. And now there is this phase 2 clinical trial going on using anti-TIGIT plus the first-line drug treatment, atezolizumab and bevacizumab going on. Well, we'll see the results later. So the systemic treatment for advanced HCC nowadays is the first line is atezolizumab plus bevacizumab. So this is immunotherapy with immune checkpoint inhibitor, and sorafenib and lenvatinib now another alternative first line for advanced HCC. And to this end, immune checkpoint inhibitor in advanced HCC, the response rate, there is positive response rate, but the response rate is about 20%. And furthermore, study on the neoadjuvant and also adjuvant immune checkpoint inhibitor therapy in HCC, they are scanty. And therefore, the benefit or the molecular mechanism and biomarkers of response of neoadjuvant immune checkpoint blockade are largely unknown. And to this end, before that, And here is a summary result of the markers of response to immune checkpoint inhibitor in HCC. Previously, people talk about, the expression of PD-L1, but recently FDA already approved the immune checkpoint inhibitor regardless of PD-L1 expression. And in fact, this is a study by Dr. Bruno Sangro. In fact, some of these patients some of these patients, with very low expression of the PD-L1 could achieve complete response upon the ICI treatment. And tumor mutation burden and MSI may have just limited application as biomarker for immune therapy. Inflammatory marker, yes, there may be some suggested parameters. And in fact, the most positive, most definitive biomarker of response is a negative result. So NASH-related HCC could lead to a lack of response. So this is a negative biomarker. To this end, we have performed a study on the neoadjuvant anti-PD-1 for advanced intermediate HCC, and we examined the omics analysis as well as a pathological analysis to understand what is the mechanism of response. So in these patients, totally we have 19 patients. 12 of them were non-responsive, and seven of them were responsive. What we did was that we give neoadjuvant therapy, anti-PD-1, nivolumab for 3 cycles. And we took the pre-treatment biopsies of all of them and also performed surgical resection in all of them to compare the response. And we took the tissue as well as the plasma. And for the tissue, we performed RNA sequencing and also FFPE blocks for the immune histochemistry. And we are also performing spatial transcriptomics, which is ongoing. And for the plasma, we examined the cell-free DNA, examining the copy number alteration as well as the mutation burden. So this is the patient's data, and most of them were hepatitis B patients, 70% of them, and most of them were locally advanced or intermediate HCC. Here is some of the pictures of pathology after treatment, after the 3 cycles of nivolumab. And this is the resected surgical specimen. So some of this is just representative case. And what we found is we found that 37%, 7 HCC cases had significant, which means that more than 60% of pathological tumor necrosis assessed in the resected liver sample. And 3 of them had almost complete, that is more than 90% tumor necrosis. I examined all these pathological resected specimen. And very strangely or interestingly, all these patients, particularly when they have a very significant pathological tumor response, there is a prominent hemorrhagic tumor necrosis. You can see here even with naked eye. And histology, you can see this hemorrhagic area. And more interestingly, that these hemorrhagic areas are often accompanied with a dense or a marked immune cell infiltrate at the tumor borders. So this is the overall responsiveness, 60%. This is the line showing 60% pathological tumor necrosis. 7, that is 30%, 37% of the patients had 60% or more than 60% tumor necrosis in the resected specimen. And the data was not mature because the follow-up is not that long. So this is the patient outcome. In patients with anti-PD-1 response, here, responsive patients, after 1 year, they have overall survival 100%, compared with the non-responsive group. They have a slightly less overall survival. And this is the same for the 1 year recurrent disease-free survival. When we examine the patient's liver tissue before and after treatment, and we examine particularly this cellular landscape and also the immune checkpoint, when we found that after nivolumab treatment, there is this increase in the CD8 T cells, particularly in the responsive group. And this is confirmed with immunohistochemistry. This is an example showing, this is a biopsy, that's pre-treatment biopsy, and this is post-treatment resected specimen. There is this marked increase in the CD8 T cells. We also look into the immune checkpoint, particularly PD-1, PD-L1, and PD-L2. We found that there's a general increased expression of PD-1 and also the related molecules after anti-PD-1. But this is more particularly prominent in the anti-PD-1 responsive cases. And we think, we cannot be definite, but we think that the nivolumab responsive cases might be more addicted to the PD-1 immune checkpoint. And in addition, we found that in the nivolumab responsive tumor, there is suggestion of this increase in the co-inhibitory checkpoint, particularly, for example, the CTLA4 and the LAIR1, etc. So it is suggestive that alternative immune escape mechanism would come into play. So this may suggest a combo treatment, combo ICI treatment may be more important in the future. We also examine the cell-free DNA from the patient's plasma using target panel sequencing, and also examine the cell-free, the copy number alteration. And we devised an anti-PD-1 score. We found that the percentage of pathological tumor necrosis in the resected specimen had a positive correlation with the anti-PD-1 score. And this is significantly different between the nivolumab responsive group from the non-responsive group. And we also validated in another cohort from South Korea. And also we tested this, our anti-PD-1 score. There's also a very significant difference in the nivolumab responsive group. And we combined the two cohorts, and we found this very significant difference. And also there's also a very high area under curve. So this is what we are doing with spatial transcriptomics using 10x Visium. We found that just a very preliminary result, in the responder tumors, immune cells seem to be more frequently infiltrative. The T cell is in blue and the TAM is in yellow. So in the responder tumors, immune cells seem to be more frequently present and also more infiltrative within the tumors. So much so for the ICI treatment and the response. I'd like to switch to another topic which we are also working on, is that liver cancer stem cells or tumor initiating cells. So these are the established markers of liver cancer stem cells, namely CD133, CD90, EpCAM, CD24, and CD47. So EpCAM is first reported by Dr. Xin Wang, so I give respect to him. And these liver tumor initiating cell markers, they are not just markers, they're not just surface markers, but they are functional molecules with individual cell molecule pathways. I'd like to show the two previous liver cancer stem cell markers that we identified. And then I will show one reason we believe is tumor initiating markers in liver cancer. So we found that we identified CD24 is liver tumor initiating cell marker because it can induce the phosphorylation of STAT3, phosphorylated STAT3 will then move into translocate into the nucleus to activate NANOT and to exert its self-renewal, tumor formation, and also metastasis, cancer stemness properties. And we also showed that anti-CD24 antibody could block this cancer stemness property. And in addition, we also identified CD47, which is a well-known molecule, is a kind of an eat me not signal in macrophages. And we found that the blockade of this CD47, which mediate captain S signaling, would therefore suppress the cancer stemness properties in HCC cells. So I'd like to spend a little bit more time on what recent work. We wanted to identify more potential surface marker of liver tumor initiating cells because some of the previous established markers will be found in quite abundance in the non-tumor liver. And so therefore we try to find some new markers. And how did we do it? We found we kind of group all or identify all membrane protein coding genes high in HCC from our cohort as well as the TCGA cohort. And we found this number of the membrane protein coding genes high in HCC. And then we use SI library to with a readout of sphere forming ability. And we narrow down to this many genes. And in each of these genes, we then perform stable knockdown RNA and also perform the sphere formation ability. And from these, we exclude these genes by that these genes need to be, we filter them with, they have to be membrane localization. We use immunofluorescence, and this number of genes remains. And then we then use in vivo assay using mouse model to test that these genes can promote tumor initiation using limiting dilution assay. So in the end, we concentrate or focus on the LANSO1 gene. So this LANSO1, we found that we confirmed that they have this LANSO1 had cancer stemness property, which I don't want to repeat. For example, self-renewal, tumor limiting dilution assay, tumor formation, also the promotion, the metastasis property. But here I'd like to just concentrate on the mechanism, why it can promote cancer stemness. We found that this LANSO1 could suppress the reactive oxygen species, ROS. So this is from the sphere formed from this HCC cell line. From the sphere, if we knock down LANSO1, these ROS could be suppressed in here. When we when we knock down LANSO1, the RS could be increased. But when we add back the LANSO1, the RS is suppressed. This is same for another HCC cell line. And because we concentrated on the RS, therefore we use the antioxidant which could suppress the RS. And we found that, for example, when we knock down LANSO1 here, the the knockdown effect, the sphere formation is suppressed. But when we add the antioxidant, NAC, this is N-acetylcysteine or GSH glutathione, you can see that the sphere formation ability could be restored. And this is the same with animal model. When we added the NAC or glutathione, the suppressive effect of LANSO-1 on the tumor initiation could be restored. And furthermore, using mass spectrometry, we wanted to know the downstream partner or binding partner of LANSO-1. We found that FAM49B is identified to be the functional binding partner of LANSO-1. And when we add the, for example, when we have the FAM49B itself, there is this increase in sphere formation ability. And however, when we knock down LANSO-1 together with adding the FAM49B, we can restore part of the suppressed ability of the sphere formation by LANSO-1. And this is also shown in the limited dilution assay to restore the tumor initiation as well as abrogating the RS increase induced by the LANSO-1 knockdown here. So this is a summary of what LANSO-1. It drives liver tumor initiation by stabilizing FAM49B, and FAM49B could reduce the oxidative stress mediated by the NADPH oxidase. So this is the summary of the mechanism of LANSO-1. And furthermore, we use the antibody, which is a commercially available antibody, anti-LANSO-1 antibody. We found that the sphere forming ability could be reduced, markedly reduced. And we found that we think that LANSO-1 is a cell surface protein and contribute to HCC initiation and possibly targeting this axis, LANSO-1, FAM49B, and RAD1 and the RS axis may be a promising therapeutic target for HCC. We also performed some signaling pathway analysis because we wanted to identify some target that can be useful for treatment target against HCC. And we started off using exome sequencing and also targeted DNA sequencing, and we found that the mutation rate of this TSC1, tumorous sclerosis complex 1 and 2, they have a high mutation rate up to 16%. And for this, if this is of these mutations are inactivating mutation, that is, they cannot produce the proper protein. And therefore, if they cannot produce the proper proteins, therefore they cannot suppress the downstream mTOR activity. Their mTOR activity will be increased. Therefore, then the downstream, the signaling will result in increase in cell proliferation and cell survival. However, the good news is that rapamycin is effective to suppress this mTOR activity. And in fact, rapamycin is, the derivatives of rapamycin are used in patients, for example, in liver transplantation to suppress the immune response. And here we found that when we, for example, when this is a patient-derived tumor xenograft, for some of these, for example, these two PDTX lines have mutation of the TSC2. And we found that they are more responsive to rapamycin. This is the tumor volume. So the lower volume they have, meaning that they are more responsive or hypersensitive to rapamycin. And we examined patients' HCC samples. And indeed, TSC2 mutations can be detected in the FFPE samples in patients. Now, this is a case with mutation of the TSC2. And with the mutation of TSC2, there is no immunohistochemistry signal, whereas the downstream phospho S6 is hyperactivated. Therefore, there's very strong positivity. And this is in great contrast with a normal HCC patient without a TSC2 mutation. You can see this is wild type. So this is the expression of the TSC2, normal expression, whereas the downstream S6, phospho S6K, phospho S6 is very, not much positive. And so the TSC1-2 mutation could be used to stratify HCC for personalized therapy, particularly with treatment advantage with mTOR inhibitor. For these, I'm just showing some of the recent work that we have done on signaling pathway. And I've just shown 3 examples here in this diagram, namely the REL-A, Afrin A3, and the EPH-A2 and RSK2. Next, I'm going to show you just one slide on the REL-A. Now, REL-A is downstream of RAS. In other cancers, there is a high mutation of RAS here. But for HCC, the mutation of RAS is very, very rare, just less than 1%. But we found that the downstream target of RAS, that is REL-A, is highly expressed in HCC, like here. And also the high expression of REL-A is associated with a poor overall survival. If we examine this one, we found that REL-A has an increased copy number gain, and it's also the upstream regulation is by SP1 and ETS2, and these drive the upregulation of REL-A, and REL-A overexpression can be kind of suppressed by this RBC8, which is a REL-A inhibitor. So together with RBC8, which is a REL-A inhibitor, together with sorafenib, we found that there is a combo effect. This is synergistic effect in an animal model in its tumor growth. Last but not least, I'd like to talk about very recent work that we have been doing on HCC is the extracellular vesicles that is exosome. Now, exosome is produced by cells and is this kind of is a kind of microvesicle, but it's the smallest size of the microvesicle called the exosome. And for exosome, it's membrane bound, and on the surface there are these proteins, and also there are protein cargoes within the exosome. It can carry protein or also mRNA. And exosomes secreted from tumor cells can exert its effect from the receiving cells, other stromal cells, and sometimes immune cells. And I'd like to just share with you one studies that we have done very recently. And we work on the S100A10, which is a plasminogen receptor. And we found that S100A10 is highly expressed in liver progenitor cells and also premature hepatocyte stages. And we found that S100A10 is upregulated in HCCs, and its upregulation is associated with the poor overall survival. In both our cohort as well as a TCGA cohort. And its upregulation is associated with slightly more aggressive tumor behavior in terms of, say, venous invasion or poorer tumor differentiation. And we confirmed that S100A10 has this enhanced stemness-related features of HCC, namely sphere formation and limiting dilution assay. They have a much stronger ability of tumor initiation. And using 2 animal models, we found that this S100A10 can promote HCC metastasis using HCC cell injection, intrasplantic injection. We inject the tumor cells into spleen and to assess the liver tumors, and also tailway injection model to assess the lung metastasis. And we found that S1-810 can promote HCC metastasis. But we further went on to identify that or found that S1-810 can be carried in exosomes. And this is from patients and from 2 HCC cell lines. So this is the EM morphology of exosomes in patients. And with immunogo experiment, we found that, so the red one, the red arrow is antibody against S1-810. The blue one is antibody against the CD63, which is a marker for exosome. So they coincide together and present together. So that's what we can say that S1-810 is present in the exosome. And we did animal model, and we inject the S1-810 exosomes before or after intrasplantic injection of the HCC cells, and then we inject the exosomes secreted from the S1-810 cells and examine. We found that this S1-810 EVs can significantly increase the tumor size, tumor numbers, and also using the tailway injection model. And then day one, we inject also the exosome, the S1 exosome. And we found that there's also increase in the bioluminescence signals in the lungs. And how does S1-810, the mechanism, the mechanistic basis, we found that S1-810 would mediate the targeting of these MMP2, EGF, and also fibronectin, which are associated with the EMT and into this exosomes. And we wanted to know the translational value, and therefore we employed the S1-810 neutralizing antibody. And we found that this neutralizing antibody, like here, can abrogate the metastatic ability of HCC cells induced by this S1-810 exosomes in liver metastasis, and as well as lung metastasis in these animal models. So this S1-810 exosome may be a potential therapeutic target against the HCC progression. For translational research, we need 4 main components. First, of course, the patients and patients' tissue samples, in vitro models, including cell lines, right, and also in vivo models. And to this end, we work very hard to achieve or attain these several components. For example, the tissue and blood bank, and also the cell lines, for example, multiple cell lines and organoids, and cell line, and also the animal models like PDDA on various animal models, and also importantly, the advanced technology platform, and particularly the bioinformatics. I think it's very important in nowadays omics analysis. Of course, correlation or collaboration with clinicians is very important to move on to clinical trials. So I just say that omics analysis has been very useful and allows significant advancement in the understanding of pathogenesis, and also enable the identification of the pathogenesis, treatment targets, etc. One step or a few steps towards a more personalized medicine. But with regard to ICR or TKI treatment, still a lack of validated biomarkers, and identification of molecular determinants in drug responses very much warranted. And I'd like to acknowledge the team from my team from Hong Kong U, another university, and also other hospitals, and also NIH, and also Singapore. So thank you very much for your kind attention.
Well, thank you so much, Irene. This is really totally false. There's so much new data and very exciting. I'm sure they will be interested by many people. So Irene's now talk is opening for Q&A. If anyone's interested to give ask a question, you can actually turn on the cameras and ask questions. So I see Dr. Iris have a question.
Yeah. I wonder what, this was really a very exciting and brilliant presentation. Thank you. I learned a lot from it.
Thank you so much.
So the liver has this vast capacity to detoxify almost any chemical structure that comes its way via the portal circulation. And it also has this great multiplicity of types of liver cancer, and also even multiple cancers within the same liver. So that's, I wonder what your thoughts are as to what might be potential reasons for these phenomena, and whether there are studies, yours or others, on germ-free animals as to whether they even have susceptibility to induced chemical carcinogenesis or viral or any other. But what are your thoughts about the possible reason for the multiplicity of tumors within the liver and different phenotypes and genotypes within the same liver?
Well, this is a great question. Yeah, for the multiplicity of tumors, there are indeed, for HCC, for example, there are multiple tumors of HCC in the same liver. And previously we did study the multiple. Can you hear me well?
Yes.
Yeah. Okay. So we did a study on the multiple tumors of in the liver, in the same liver with HCC, and we found that they are not of the same clone. They are, some are just representing intrahepatic metastasis, and some represent multicentric occurrence, which constitute, I remember that constitutes 40% of our cases. So why is that there is this multicentric occurrence with different clones? I think is due to the field effect. For example, in HCC, and the background is often cirrhotic, high percentage of cirrhosis in the background. And in addition, for example, in our locality, HPV is the main risk factor, and the integration of HPV into different cells may be different. So it can be a cause for the multiclonal HCC appearance. Yeah.
Okay, Irene, would you mind unshare your slide so we can actually all see each other?
Okay, yes, thank you.
Great, and thank you. Yeah, so any other question from the audience?
So Shin or Irene, I actually, I really enjoyed the talk, and yes, I agree with everybody. That was a lot of data, new data to digest. Now, the problem is you have so much data. You touch about checkpoint inhibitors, CD47, and then you end up with the EVs.
Yeah.
Which pathway do we choose actually? If you really look at all these potential options, where do you think is the money? What do you think is the most likely project path to move forward and really have an impact? Because, I'm kind of like, I have so many options now and I'm like lost.
Yeah, it's a difficult question. I mean,
Sorry, I'm always asking difficult questions. Shin knows that.
yeah, it's difficult. And it's kind of, nowadays the research field or community are working so hard, working from all fronts to tackle HCC. And still after that many years that, in fact, it's not very successful. There is no magic drug, there is no magic, biomarkers. So I would say that people are working in all fronts to target this very difficult question. And it's very difficult to say, oh, this is not important and that is not important. For example, a few years or 10 years back, people are chasing to look for mutations, driver mutation, oncogene mutation, and thinking that if one could find an oncogene, okay, driver oncogene, that would be great. And there's drug, okay. But then the scenario has changed, that. There is no successful anti-oncogene drug, that can work, So people now have switched on to immunotherapy. And immunotherapy, 20% of, ICI treatment work in HCC patients, but the remaining 80% that do not work. So what else? Now we're talking about combo treatment. We're talking about combination, not combo, but TACE plus, ICI. So it's kind of the scenario is changing very fast, very, very fast. So if one can see the future with the crystal ball, I think this is $1 million. Yeah.
This is a very nice way of answering Tim's question. Well, I have one general question, one more specific question. I think it's interesting that, no, this is more technical. You have this trial with a 19 patient treated with a nivo, and then you have this is a neoadjuvant, you have a before, and then you have the surgery. Are those patients for downstaging, basically?
It's not for downstaging. It's unlike, say, there are two or three previous work talking about neoadjuvant ICI to downstage. But for our study, it's not really a downstage. It's intermediate. It's not just advanced. It's an intermediate stage. Okay. So it's to, according to the surgeon, it will be, after ICI, it will be easier to do the surgery.
What's the time difference between the
3 cycles, which is 6 weeks.
6 weeks, I see.
Yeah.
Okay, so your time difference between the 2 samples are 6 weeks.
Yeah, and I'd like to say a few more is that, many surgeons may not like to adopt this neoadjuvant therapy because they think, oh, what should I wait for 6 weeks or certain weeks? I'd rather go in and do the resection, right? Otherwise, say this time may aggravate the tumor to grow. So not many surgeons would kind of buy the idea of adjuvant therapy before surgery. Yeah, but one has to demonstrate, oh, this neoadjuvant therapy or adjuvant therapy should work. If they work, then it would be good for the patient.
I have one specific question. This is more related to your exosome study. And we know that the liver stiffness, particularly if you have fibrocirrhosis causing stiffness will lead to a production of excessive exosome. This is a study done by Wei Guo and several other people. And those could inducing cargo, that cargo will mess up with tumor microenvironment and lead to change of the immune treatment. Have you done anything by linking in your exosome study, connecting those to
sorry, yeah, could you repeat? Yeah.
have you done anything for the level of exosome to tumor stiffness? So for example, cirrhosis that connecting to, for example, treatment response.
For that exosome study, we did it on animal model. So these animals did not have cirrhosis, but I think I agree with you that it would be good to test in patients because in patients with cirrhosis, then there is increased stiffness, and we know the stiffness of whether the tumor or the adjacent liver tissue would have this effect on the cancer stemness, right?
You can I guess you can certainly introduce since titanium carbon chloride treatment or some other that induce fibrosis, for example.
Yeah, good idea. Yeah.
Okay. Any other question from the audience?
Hi, Irene. Can you hear me?
Wonderful.
Yeah, I have a question. And also I've been very interested in your exosome marker for the HCC. How promising do you think to use the exosome markers to treat HCC? And any other examples or published data to show any outcome for the treatment using the exosome markers?
I think for an exosome to be a useful marker for treatment of HCC, I think there are nowadays quite a number of preclinical, I must say preclinical. So working in animal models yet, and not yet in a human being. So for an exosome to be qualified as a treatment, good for patients' treatment, it needs to be shown that exosome is not just released by tumor cells, but also it needs to be shown that the exosome is only highly expressed by the tumor cells and not in the, say, non-tumor liver or other normal tissues. No, but I'm not aware of, exosome going to do the treatment yet, but it can be used as a marker. For example, a marker of diagnosis or marker, for diagnosis. Yeah.
Okay.
Thank you.
We have one, I think probably we have one probably last question by Dr. Changjin Xie. Changjin, you want to ask yourself, or I just read this question for you?
Oh, okay. Irene, nice talk. I learned a lot. And one quick question: when you screen the surface marker for the HCC tumor cells, are those 16 kind of candidates cover the well-known surface marker?
Yeah, they do. We do, but we eliminated those that have been published very extensively in the literature. So if you see those, one of the criteria is that these markers are not reported well in the literature. So we were trying to find novel markers. Yes.
Thank you.
Okay, with this, I think we are right in the top of the hour, so I'm going to closing this seminar. Well, let's give it a round of applause. Thank you for Irene's wonderful lectures.
Thank you.
Thank
so
you,
much,
Irene.
Shin and Tim and Anu. Yeah, thank you very much.
All right. See you.
Hi, David. Good to see you. Oh, bye-bye.
Bye.
Bye-bye.